Hello friends, welcome to Medicine 101. Today we'll talk about infective endocarditis. Okay, the topic is infective endocarditis. So from the terms, it's very easy to understand what we mean by it. Okay, so infective means definitely there are some types of infections, and endocarditis means the inflammations of the endocardium. Now, if you draw the heart structures, yet it's not anatomically correct, but for functional purpose, I just do it here. Let's try to understand the innermost structure that is covering the valve over here, the leaflets. Okay, this aortic valve over here, that is the endocardium. This is the endocardium. Okay, now if you talk about under normal circumstances, under normal physiological circumstances, if you talk, then there is no endocarditis of normal individuals. Why? Because if you see the structures over here, okay, let me show with the red one. If you see the structure over here, okay, it's not working. Let me show this one. If you just see the endothelial lining or the blood supply within these regions, the microcirculations, if we see as aspect of the microcirculations over here, okay, now these regions, the endothelial cells of the endocardium of the particular region is not getting involved or not damaged by any kind of regions. Okay, now the endothelial cells are normal in these situations. So for the normal endothelial cells, normal endocardial endothelial cells lining, okay, endocardial endothelial cellular linings. Now in these cases, what can you see? The normal endocardial endothelial cellular lining, so there will be no problem as far as the endocarditis is concerned. Okay, now the next thing is over here that for examples, for any regions, okay, for there is a little bit cut in the skin injury, or when you are going to brush our teeth, at the time there is chances for the bacteria to go within the circulations for the very temporary period, that they can cause the transient bacteremia. So you can see over here the transient bacteremia. Now transient bacteremia we can see over here. Now whenever we get the transient bacteremia, after that the normal immune activations will be there. So under normal circumstances, the activations of the immune system will be there. So whenever the activations of the immune system will be there, so we can say activation of immune systems. So whenever there is a transient bacteremia, the immune system will come over there, and we'll see at first the different types of the antibodies. Okay, I'm just stating the antibodies will come over here. These regions will be activated. So at first the antibodies will come over here, then we'll see the complement systems. Okay, the complement systems will come over here. After that we'll see the different types of the inflammatory cells, IF cells, inflammatory cells like the neutrophil, or monocyte macrophages, they will come over here, and they will just try to neutralize the situations. Okay, so these three are the protective factors, that will not lead to cause the infective endocarditis. So I'm writing protective factors over here. Now then, what caused the infective endocarditis? The positive agent for the endocarditis, for example, if we say for predispositions of the disease, for examples, the classical example we can say in terms of the rheumatic heart disease. In case of the rheumatic heart disease, you can talk about it, or you can say whenever there will be congenital heart defect. So like the congenital heart defect, just like we can say in terms of the ventricular septal defect. The ventricular septal defect, in these cases we can see, or in case of the artificial valve replacement or prosthetic valve, artificial valve. In these cases, we will see there is a chances to get affected for that can cause the infective endocarditis. So these are the positive factors. We can say the causes. Or we will see in this time, we will see this endothelial cellular linings will be not fixed like this. There will be alterations with the endocardial cells. Okay. Now, if I say, for example, there will be antigens will come over here. Whenever the antigens will come over here, like the bacterial antigens, so definitely the antibody will come over here. Then the different types of the the inflammatory cells. I'm writing here IF cells means the inflammatory cells will come over here, and there will be then this endothelial cells, that will be what these structures will be not like just like this. Now it had a property for before this all types of the things, it has a property. So whenever through the circulatory systems, the for example the platelets are going through it, the different types of the clotting factors. For example, if we talk about the fibrin that is going through these regions, so they will try to fuse with the endothelials, but within the endothelium, there are nitric oxide, or there are also many other factors that will not let these factors to get stuck over here. But whenever these cells are getting damaged, the endothelial linings is getting damaged. As a result, this property will be lost. So ultimately, we see the fibrins, okay, and also the the platelets, they will just get fused over here along with the different types of the bacterial antigens, and they will form a vegetation. So I'll talk about those things, okay, within a couple of minutes. Vegetations. So these types of the thing we can see over here. Now this is a little bit of the pathophysiology. Now, or for example, and persons who is immune compromised. For example, the person who is immune compromised. So that persons can also get affected by these types of the bacteria. They can cause the infective endocarditis as well. Immune compromised. Okay, these type of the things. Now, what type of the problem we'll see over here? For example, if we just classify the infective endocarditis, for example, the divisions of the divisions of infective endocarditis. First, we'll get the acute infective endocarditis. For example, there is a okay. Let me just complete the division. Then I'm saying. Then we'll get the subacute infective endocarditis. Then we will get the prosthetic valve or the artificial valve. Then, for example, I am talking about the intravenous drug abuser. I am writing IV stands for intravenous. Okay, drug abuser. Now, first thing first, I will go through the acute infective endocarditis. For example, this endocardial lining or endothelial cellular lining is normal. There was no previous damage. So for instance, for the first time, if the damage is there, that is considered as the acute infective endocarditis. So we can just write down the features of the acute infective endocarditis. Okay, no previous damage. So no previous damage. Then you can consider that in these cases we will also see that whatever the bacteria that will attack for the first time, that is the virulent. The virulent bacteria that will attack over here. And the most common type of the bacteria that can cause as a staph aureus. Okay, in case of the acute infective endocarditis. Staph aureus. Staph aureus. Okay, so acute infective endocarditis also you understood, I think. Now, if I say in terms of the subacute infective endocarditis, whatever the problem we'll see. Let's suppose I said already, in case of the acute infective endocarditis, for the first time the endocardium is getting infected. The endocardial, endothelial cellular lining is getting infected. But if you talk about in case of the subacute, infective endocarditis, for example, there is a person who had already infected, there is a problem in the endocardium. For example, if we see in terms of the RHD, rheumatic heart disease, or congenital heart defect, or ventricular septal defect here, or artificial valve. So there is already problem. There is already damage of the there are already damage in the endothelium of the endocardium. Now again in the new, if you see another type of the damage. So the damage on the, if you see the damage on already damaged endocardium or endocellular cellular lining, this type of the problem we can consider in terms of the subacute infective endocarditis. Okay. So in these cases, whatever the features we can write over here, the previously already damaged one time. So previous damage you can consider the previous damage. And in this case, previous damage means we can talk about in terms of the RHD, rheumatic heart disease, or we can say in terms of the ventricular septal defect, or we can say in terms of the prosthetic valve, or I'll just say these things in different ways. Okay, so ventricular septal defect or immune compromised The person is there already from the first time. So this type of the problem we will see. Now what type of the most commonest bacteria we will see here over here? The most common type of the bacteria that can cause that is the Streptococcus viridans. Okay. Streptococcus viridans or viridans you can say. And you have to remember in this way that's the group alpha hemolyticus. It's the alpha hemolyticus. Okay, alpha hemolyticus. Now if we say in terms of the prosthetic valve, so prosthetic valve, that means for example the valve that is not working well or that is getting damaged, for it we need to replace by an artificial valve. So we can say another term for the artificial valve. So that is also vulnerable to get affected by, on top of also bacteria you can see over here, that is the Staph aureus. Okay, let me write in this color over here. Staph epidermidis. Staph epidermidis. Okay. Now, if we talk about in terms of the intravenous drug abuser, the intravenous drug abuser means you have to consider in this way. Let's suppose there is a person who takes drug, then whatever the problem, whenever he is taking the drug through the intravenous systems by the veins, at first from this vein that the drugs will go through the larger vein, then ultimately it will go to the superior vena cava or from the lower limb to the inferior vena cava. Ultimately the drug that will reach to the right atrium. So from the right atrium the blood will go to the right ventricles by the tricuspid valve. So the most commonest regions to get affected for the intravenous drug abuser, that's the tricuspid valve. Okay, so we can write over here, the persons who is not maintaining the hygiene life, don't maintain hygiene life, okay, and in these cases we'll see the most type of the commonest bacteria, that is Staph aureus. That is Staph aureus, that is the positive agent here, and there is the chances for the tricuspid valve injury, the most commonest type of the valve. Okay, there is a tricuspid valve that can get affected for these reasons. Okay, now there are some uncommon bacteria. Okay, let me write it over here. There are some uncommon bacteria that can cause also here. Uncommon organisms, you can say in terms of here. Uncommon organism, that means, let me explain a little bit of this part. Let's suppose that a person has come to the OPD and he is complaining, or you understood the person is suffering from IBD, inflammatory bowel disease. So, for example, the person is having the inflammatory bowel disease. Let me write it over here. The IBD, that means inflammatory bowel disease. I am not writing little, full form. So, why the IBD? Because he had before the ulcerative colitis. Okay, so here the ulcerative colitis, and the ulcerative colitis caused by the Streptococcus. Moving. Okay, now if we see in this way that Streptococcus bovis that caused first the ulcerative colitis that leads to ultimately the inflammatory bowel disease. Now the Streptococcus bovis, this Streptococcus bovis is having a co-relationship or definitive, we can say the definitive, co-relationship or relation with infective endocarditis. So ultimately we can say that can cause, so the ulcerative colitis causing the bacteria, that is Streptococcus bovis, that can cause also the infective endocarditis. So this is the relationship. Now we will talk about in terms of, let me show it once again. There are some types of the group of bacteria that are known as the HASEC. Now, what did I say? HASEC. HASEC bacteria means there are some types of groups of the bacteria that can't be cultured in the culture medium. So they are within the culture medium. If you see the, the growth rate, we will see the negative result. So we will see the growth on the culture medium, it will be negative. So can't be cultured. We can write it over here. So can't be culture on the culture medium. So sometimes just like this we can say this lactobacillus. We can say the lactobacillus. Okay. Over here on examples. Okay, so they will give the negative test on the culture medium. Or you can also remember just like the hemophilus. Okay, hemophilus you can remember lactobacillus. So they will give the negative result. Now, for example, there is some types of the bacterial infiltrations over here. Now, if you get the negative test on the culture medium of those bacteria, then you can consider those bacteria where they are the Hesse group of the bacteria. Okay. Now, what about the clinical features or clinical manifestations we can get over here for these things? We'll get the clinical manifestations over here. That definitely whenever the infection is there, so definitely the fever will be there. Okay. Now, along with the fever, what I already explained you, there will be different types of the vegetation formations. Okay, how is getting formed I already said you. So whenever the vegetations will be deposited over here, they will cause the abnormal heart blood flow in the heart. They will cause the abnormal blood flow in the heart, and that is known as the murmurs. So they will cause the murmurs. So murmurs positive will be there. So this murmur positive is the diagnostic feature. So you can see in another way. Diagnostic feature for it. So along with that we will also get the weight loss of the individual. So these are the features. Now whenever I will say already said you that for example in the circulation, within the circulations, where should I show it? Let me use a little bit of this part, then you can understand it better. For examples, within the circulations, I don't have the right now the red one, so I'm showing it here. Within the circulations, let's suppose these are the antigens over here. So whenever the antigens are coming over here, definitely from our body, the immune system will be activated, and they will try to produce the different types of the antibodies on the antigens. Now, whenever the antibodies and antigens are getting combining together, they are forming the complex antigen antibody complex. Now they can deposit it on the many organs, on the tissues. Okay. So as a result, we can see sometimes the vascular and immunological lesions. So we can see the vascular and immunological lesions. So the vascular or immunological lesions over the different organs. Now these vascular lesions we can see, if we see in terms of the retina, there we will see on top of the thing that is known as the Roth spot. Okay, in case of the retina, if we see these vasculations like the Roth spot. Vasculations, the vascular lesions we will see over here. Okay, so these are the clinical features we can see also over here. Then if we see in terms of the palms, in palms and the soles here over here in the legs, so we'll see there is a painful lesions. Okay, so we will get over here the painful lesions. So we can get the painful lesions. That is known also as the ossular lesions. So ossular lesions. Or also we can get the painless lesions on the palm. Okay, so painful lesions where we will get on the palm and sole. So that is known as the ossular lesions, or we can also get the painless lesions, or where in the same positions, but this is known as gem-OA lesions. Gem-OA lesions. So we'll get the gem-OA lesions where in the palm, but that is the painless. You have to remember in this way. Okay. Now we'll talk about that. I already explained in one of my video that there is similarities, dissimilarities to the rheumatic heart disease and the infective endocarditis, and I will talk about them. Before going to that, if you want to classify the infective endocarditis, there are some criteria that is known as the Duke's criteria. Just remember, just like this, I only talked out in terms of the where. In terms of the rheumatic heart disease, I talked about the Jones criteria, where there are some major factors, some minor factors. Okay. So it is the major criteria, minor criteria. Similarly, I will explain over here. In case of the infective endocarditis, you can get the Duke's criteria. So whatever the criteria you can get over here, let me show it here. So we can get the Duke's criteria. we just consider the Duke's criteria over here, we'll get some of the major criteria and some minor criteria. If we want to talk about the major criteria, we'll get over here. First things that we have to do the blood culture over here, just to make sure that what type of the organisms are there. So the blood culture that must be positive as far as the Duke's criteria is concerned. So this blood culture should be done minimum 2 times. So 2 blood culture, you can write it just like this: 2 blood culture should be done 12 hours apart. So okay, the second thing is that there should be the echocardial findings. Echocardial findings. That should be the echocardial findings. So this should be also positive. So in these cases, as far as the Duke's major criteria is concerned, we have to do the blood culture 2 times, and you have to find out in terms of the echocardial findings. Now if we talk about in terms of the minor criteria over here, if we talk about in terms of the minor criteria, we'll get over here the fever, we'll get the predispositions of the different types of the, already in case of the RHD or mandibular septal defect, the predisposition of the heart, or you can say the vascularitis, or what did I say over here, that we will get the different types of the vascular and immunological lesions. So the vascular and immunological lesions. So these are the minor criteria, these 3, and the first one I said over here, this is the Duke's major criteria. Now friends, I'll talk about the very important thing. Okay, there's the differences in between the infective endocarditis and rheumatic heart disease. What is the main difference in between the infective endocarditis and rheumatic heart disease? Let me write it here: infective endocarditis, and I'm writing with the black one, the rheumatic heart disease. I have already explained how the vegetations are getting formed. Okay, so whenever the vegetations, will see the formations of the vegetations over here, how they are getting formed. Already said the mechanisms. Now I'll say, for example, if I talk about in terms of the infective endocarditis, in these cases, these vegetations that can be enlarged. So there will be large vegetations. Okay, that can be single, that can be single or multiple. That can be single or multiple. And whatever the thing, this is getting attached with the endothelium, endothelium of the endocardium, that is very firmly attached with the endothelium of the endocardium. Okay, and whenever this type of the, if we just consider these valvular structures of it, then we will see a vegetations over here, the circular ring. We'll get the circular ring over here, in these cases. Okay, and another thing is here that there is a chances for these vegetations to get detached as they are bound loosely. So these vegetations can get detached from these regions and can form the emboli. And that can go to the different organs, especially if we talk about in the CNS. So they can cause ultimately the metastatic abscess. So that can cause the metastatic abscess within the CNS, for example. Okay, that can go to the spleen also. That can go to the spleen or kidney, or also they can cause the different type of the problem in these organs. Okay. Now, if we talk about in terms of the RHD. Now, what do we see in case of rheumatic heart disease? The vegetations that will be along with the line. That will be the vegetations that will be along with the line of the annulus or the cursors. So here we will see the small multiple. So as for small vegetations, small and multiple vegetations will get it here. And this vegetation is getting attached with the endothelium of the endocardium tightly, so there is no chances to get detached. Tight binding of the vegetations with the endocardium. Okay. Now what are the next problem we can see over here? That okay. In these cases, that these vegetations, what we are seeing, is circular way, but here if we try to draw the heart, okay, for example, just like this, the vegetations will be just like this. Okay, not they will not form the circular rings. Okay. along with the line over here. Now, as we know, in case of the rheumatic heart disease, there is no microbial, infiltrations over here. So whatever the vegetations will get over here, that will be sterile. But in case of sterile means, we have to write in terms of, we'll get the fibrin, we'll get the platelet, we'll get also the inflammatory cells, just like the neutrophils, macrophages over here. But in case of what we get, it will be the non-sterile. It will be non-sterile vegetation. The vegetations will be non-sterile. Here we will get the fibrin, we will get the platelet, we will get the the inflammatory cells. We will get also the microorganisms. The different types of the bacteria already described over here. Okay, this type of the changes we will see or differences in between them. Now there is also one difference that is known as the differences in between the SLE and the NBT. So I'll talk about this part in the next part. Okay, the SLE and NBT. So this was enough for today, I think. So if you don't understand, require let me know in the comment sections, and if you understand, please do like and subscribe my channel. Don't forget to subscribe. And whatever the video do you want, just let me know in the comment sections. I will try to help you guys with my level. Thank you for watching, and don't forget to subscribe.